So this is a randomized phase 3 study called the CROWN study comparing Lorlatinib 100 milligram with crizotinib 250 milligram twice daily. The primary endpoint is actually progression-free survival. Now with that, we have the primary analysis in 2020, published in New England Journal of Medicine. The median progression-free survival not reached. But again, at 5-year, 2024, we also look at the progression-free survival is not reached. But now that's why we look at the 7 years data. And then looking at the 7 years data, actually the median progression still has not reached. But at 84 months, there's actually 55% of the patients are still progression-free. So in other words, the median progression-free has to be beyond 84 months. Now, because of this long stretch, we were also able to look at the dynamic of the changes of the events. So we noted that in the first 2 years, the progression occurred in 20% in the first year, 10% in the second year. But in other words, from second year onward until now, there's only 15% of patients have progressed. So for someone who had achieved the progression-free at second year, there is a probably close to 80% chance the patient may still be progression-free at the end of 7 years. That's a reasonable question. So in the first line, we already have a number of choice, first, second, and third generation. Now, the first generation, we may not consider anymore because it does not have a good CNS penetration. So almost like 100% of the patient with brain met progressed on crizotinib, as a first line. So I think we've probably choose between a second generation and a third generation drug. Now, for the second generation drug, Lorlatinib, the median progression-free survival is 34 months. And the overall survival is about 83 months. I presented this data just about last year. But now with the Lorlatinib, at the 7th year, the median has not reached, and then with 55% of patients still non-progressive. So the chance is that the overall survival will be longer. So I think that this information needs to be discussed with the patient, of course, in the balance with the toxicity, so the patient can make a wise choice for themselves in terms of efficacy and the toxicity. Now, the term chronic disease is a challenging one. I think in a sense, if we consider diabetic, hypertension to be a chronic disease, but then the patient needs to be on medication. Now, with advanced stage lung cancer, we have difficulty in a sense is that the patient needs to be on treatment, but then the treatment also had a moderate toxicity we have to manage. So I think the objective now is that with drug like Lorlatinib, we have to learn how to maximize efficacy. In the meantime, minimize the toxicity. Dose reduction is actually one of the most important strategies in this regard. Now, for the future, I think today there is another presentation by Jessica Lin, the ALK study, that demonstrated the 4th generation drug may still have some efficacy after Lorlatinib failure. Although the response rate is only moderate at actually about 26%, but at least there is one effective target therapy. In the future, I think there are a number of new technology available for ALK, including a degrader, which is actually in early study. And also in this ASCO, there will be another early stage study on the vaccine against ALK. And I certainly look forward to those research outcomes in the future.